one scan, one lifetime rewritten. That is with respect to breast cancer screening, where in the urban areas, the incidence of breast cancer is on the rise. We celebrate October as Breast Awareness Month, and we would urge our viewers to get breast cancer screening done at the nearest hospital. So, at what age should women start screening the breast?
So as per the data, it is 40 years plus. They require to do a mammogram plus ultrasound scan.
How often should this screening be done? Should it really be every year, or can we make it alternate year?
Any density which was not there in the previous and it is present in the next mammogram, it is an earliest indication of the malignancy. So it is better to do every year.
Welcome to OncoFlix podcast. I'm Dr. Lohit Reddy.
And this is Dr. Kritika.
Today we have with us Dr. Sudhakar Sampangi, a renowned breast radiologist. One scan, one lifetime rewritten. That is with respect to breast cancer screening, where in the urban areas, the incidence of breast cancer is on the rise. And today we are going to discuss on the topic of breast cancer screening. Welcome, Dr. Sudhakar.
Welcome, sir.
Thank you, Dr. Rohit. Thank you, Dr. Kritika.
So, at what age should women start screening the breast?
So as per the data, it is 40 years plus. They require to do a mammogram plus ultrasound scan. If they have a family history, they have to start screening by 35 years of age. And the self-breast examination has to start from 20 years of age.
So, how often should this screening be done? Should it really be every year, or can we make it alternate year?
Ideally, it should be every year, because whenever there is one of the criteria for us to say abnormality is an asymmetrical density, or we can also say it as developing asymmetry. Any density which was not there in the previous and it is present in the next mammogram, it is an earliest indication of the malignancy. So it is better to do every year.
Every year.
Correct.
So, what is the advantage of doing a mammogram? And the other question is it going to be painful if you have to do a mammogram?
Because many people fear this because mammogram may be painful. That's why they don't come for screening.
So mammography is a test where it is universally been accepted, and any trained radiologist can read that. And when it comes to ultrasound, it is individually driven by the expertise of the business. So when it comes to mammogram per se, mammogram, again, the density of the breast vary from person to person. But overall, the sensitivity of the mammogram vary from 60 to 90%. But it is universally be read by anybody. So it is, and we follow guidelines of ACR. So that will be easy for us for interpretation and recommendation. And coming to the pain, earlier days we used to have a conventional mammogram where when the breast is compressed, we exactly don't know how much to compress. See, the compression is to give a good density has to be removed, and overlapping of a tissue will be avoided. So for that reason, you have to do a compression. But when you use an analog system, we don't have a definite how much to compress, we don't know. But nowadays, what we have is a technology wherein how much is the minimum compression required to obtain an optimal image. That the machine will tell. That's called AEC. That is there in all digital machine. So that will give us an indication what is the minimal density is, minimal compression is required. So this is compared to analog machines, it is less painful.
Okay. So that's interesting. That bit of information is something that is very useful to the society, that the present age mammography imaging uses technology to find out what the necessary compression is. So when do you suggest ultrasound to be a more useful modality than mammogram for breast imaging?
So when it comes to mammogram can detect the lesion, but it cannot describe the lesion fully. For example, when there is a fibroadenoma is there, when there is a cyst is there, when there is a solid cystic lesion is there, it all looks like a benign on the mammogram. But when I do an ultrasound scan, I can characterize whether it's a solid lesion, whether it's a cystic lesion, or it's a mixed lesion, and I can also see a real-time Doppler. So Doppler is a one which gives an indication whether the tumor is having more vascularity or less vascularity. So that gives a very good dynamic study. And whenever the vascularity is higher, it's more towards a suspicion. And I can also describe more better in terms of the margin of the tumors. When the mammogram, it is an overlapping image. So ultrasound is not an overlap. You can change the direction of the probe, the way we hold it, and it is not painful. Because we are going to gently press, it's manually done. So we are going to gently press if the patient has a pain in that particular point. But mammography is not like that. We have to compress the whole breast, even if they have a pain on one part, but we have to compress the whole breast. But ultrasound is not like that. Wherever there are a lump, especially for the painful lumps, we don't do a mammogram.
So we can say that ultrasound is complementary to mammogram in many places, but have there been instances where mammogram didn't detect a lesion but ultrasound did?
Definitely. There are at least in our institute, 30 to 40% of the women who have done a mammogram will be normal. So that is because most of the Indian women's, there is higher densities there. We
The
call
breast
it as
density.
the breast density is high. So when it is a type C and D, which is a higher density of type, that type, since it's a overlapping image, we are going to miss. Even if the small lesions is there, architecture distortion is there, that we are going to miss it. So you should, when there is a type, high density type is there, it should be complemented with an ultrasound scan.
So you spoke about two imaging technology. One is the mammogram and the ultrasound. Moving on to MRI. Okay, that is the highest level of imaging. In breast screening, when do you incorporate MRI? And how is it going to be useful in the screening process?
So MRI is, as such, it gives a very good contrast between the parenchyma and the blood vessels and the subcutaneous fat. And in MRI, we always give a contrast. MRI contrast will be given. So where the tissue gets enhanced, the background parenchyma enhances, and also the lump will enhance. So when the lump gets enhanced, so based on the enhancement pattern also, we can describe. One thing. Second thing, some patients, they have a family history of P53 genome deficiency, something like that. So where they are grouped under high risk family. So in the high risk category of the breast cancer history, every second year or third year, we will do a MRI scan where we give a contrast to see a lesion which is non-mass like lesions can be picked up in a MRI scan.
MRI. So is it mainly for the younger women, dense breast, younger women, to quantify or, to have a proper evaluation of the breast lesions, the MRI has to be done?
So MRI, when it comes to a screening population with the family history, it's always required once in second or third year. But when it comes to diagnostic mammogram, diagnostic MRI scan, where suppose one lump is there on ultrasound and mammogram, when you do MRI, we can pick up many other small lesions. This is definitely useful when a surgeon is planning for breast conservative surgery. So he wants to know, is there any other smaller lesions which he don't want to miss it out. So that's the reason all breast conservative surgeries, before planning for a surgery, they will get a MRI to rule out a multicentric disease.
So what are this thermal scan, which is becoming popular right now?
So thermal scan is an image. So whether the lump is hot or cold, that will be detected. So it's a sense where any lesion which has to have a vascularity, when vascularity is high, the surrounding the normal parenchyma, compared to that, it will have more vascularity. So when more vascularity will dissipate more heat. So that heat will be absorbed in the thermal camera. So here, the advantage of thermal camera is can be repeated a number of times, and it can be seen at any age. There is no age restriction for the thermal scan. Even a lactating woman can also do it, and tender breast we can do it. There is no radiation, and it is non-contact. And this is approved by FDA. FDA has approved as a screening modality. When you do a thermal scan, you have to do an adjacent, along with the mammogram, along with the thermal image, you have to do a complementary ultrasound scan or mammogram as a supplementary model.
Okay, so my next question was that, so we recently had a patient who came to us with a report of thermal scan and it showed some abnormality which could be benign. Now, she was advised that a mammogram or ultrasound may not be required because the thermal scan was done. So what is your view of that?
So definitely as per the FDI guidelines, the license also obtained in stating that thermal imaging, after thermal imaging, you have to confirm the type of lesion. The advantage with the thermal imaging is it is a functional image.
Right.
It not just gives you a definition of hot or cold. There are a couple of instances where the women have a premenstrual heaviness, breast pain, where mammogram is normal, ultrasound is normal, even MRI is normal, but patient continues to have a pain. So that is the cases where the thermal scan is very good. So it picks up where is a hot spot.
Inflammation.
So any inflammation will pick up. Most of these hormonal related inflammation are better picked up in thermal scan. The advantage for us as a clinician is once you identify the hot spots, you give tablets for that. Right. And after that, you can follow it after 1 month to see whether it is responding to your treatment.
So it is supplementary, but it cannot replace the standard mammogram and ultrasound.
In your clinical practice, you see a lot of breast cancer screening patients. You always use a combination of mammogram and ultrasound together to better screen your patients.
Definitely. So whenever we, as I said, the density of the breast is the main culprit for us where the mammogram will miss. So to avoid this missing cases, we always do an ultrasound scan to confirm whether the density of where the density is high, is there any lesion or no? First thing. Second thing, whenever there is the ductal lesion, duct is the one where the milk is stored. Ductal lesions are missed even in MRI scan, even in mammogram, because there are very tiny structures. Most of the time it is a papillomas or early DCAS, which are very mild kind of tumors that can be missed on the mammogram and MRI. So we always do ultrasound scan whenever there is a bloody discharge or nipple discharge is there. You have to do an ultrasound scan to delineate the whole of the duct. Second, we can describe the disease. We can describe the mass much better compared to mammogram. So it gives a complementary for a mammogram findings.
What is this 3D mammography?
So 3D mammogram or tomosynthesis is nothing but a mammogram where in the regular mammogram we take a standard view to craniocaudal view to ML view for the both breast. But here in the tomosynthesis, one craniocaudal compression, we give a serial movement of the exit tube. So that means you get at least 10 to 15 images for one craniocaudal view. So this just like a CT scan, we get a multiple slices of the mammogram. So the advantage here is, even though it is a dense breast, which we miss the lesions on the regular 2D mammogram, 3D mammogram beautifully detect because we have a serial sections of 10 to 15 sections of the same view. So where the overlapping is avoided.
So how different is it from doing a CT breast directly?
CT breast cannot detect the lesions.
Right. So the compression and the angle from which you shoot is important.
Yes.
Right.
CT breast is not a modality for imaging the breast.
Although tomosynthesis concept is very similar to a CT, the compression and the angle at which you take makes it different from a routine CT.
So that's a good question. The CT scan and the tomosynthesis, the energy levels what we use in the CT scan is very high.
Right.
So it cannot detect it cannot differentiate the soft tissues. Whereas when it comes to the mammogram, the dose range what we gave is 25 to 35 kV. That is very good for the soft tissue.
Right.
So you have a better soft tissue characterization in the mammogram.
Right.
But whereas we have a better characterization of the CT when it comes to bone or other soft tissues,
Okay.
not for
Okay.
the
Well
breast
explained.
tissues.
Well explained.
So I had a recent patient who had undergone a regular health checkup from another, multi-speciality hospital. So usually in the health checkups, we see, patients do undergo a mammogram, okay, and they had undergone a mammogram, but then, over a period of time, over a period of 6 months, she developed a lump in the breast, and that is when she came. She got evaluated, and in the ultrasound, you did the ultrasound as well, and in the ultrasound, you did find a mass. So how often does mammogram show negative and ultrasound could pick up the lesion?
Yeah, whenever there is a dense breast, there is always a possibility of
So this
missing a
patient was
lesion.
around 34 years of age.
So whenever it's in younger age, between 25 to 45 years of age, generally 80% of the women have a dense breast. When it's a dense breast, there is a high chance that the mammogram can miss out the lesions, especially in an early stage. When the lump is already formed, it will not miss.
And how often do you see these kinds of scenarios in your clinical practice?
So whenever it is a dense breast, out of 100 cases, at least I can see missed out cases is 30 to 40%.
Oh, that's a lot.
So, in your view, how important is the expertise of the radiologist who is screening the breast? So, as you told, both mammography and ultrasound, there can be a lot of individual patient variation depending on the breast density and other factors, including the technique. So, how important is the expertise of the radiologist in picking up these lesions? Let's say somebody who's inexperienced versus an experienced doctor, what percentage of difference would you say in picking up cancer early?
Yeah, definitely it makes a huge difference because the early detection in terms of, let us see, size wise, when you can pick up the tumor less than 1 centimeter, 10 millimeters, it definitely requires an expert. When it becomes clinically palpable, you need not struggle to pick it up because patient already knows and the doctor already feels that. You're just going to discuss. No point in adding value instead of, you can just add value to that. But when it comes to an early detection, it definitely requires an expertise where when it comes to 1 centimeter lesion, less than 1 centimeter, we can't describe the mass. We can't describe the margins. We can't detect the Doppler. So there, you have to look at the comparison of the normal parenchyma versus the abnormal area, and you have to take the consideration that the patient age and the patient breastfeeding, how long they stopped it, and what is their hormonal status. So all those things makes a difference.
So we often see that us being a tertiary care center with you having that expertise in picking up things which others may not be able to. We often see patients being referred where they have a report that says it's normal or the ultrasound says it is suspicious, but biopsy is negative, but they still are able to feel the lump. So those are the cases that, in our personal experience, we have referred to you and you have picked up the right area to do the biopsy and it has been proven positive. So what is your secret for getting the right chunk of tissue to prove the malignancy when it is a lump?
So here, when it comes to a lump, palpable lump, the size of the lump will be more than 2.5 to 3 centimeters. Before that, generally it won't be picked. So when it is more than 2 centimeters, we have to see the internal characteristics of the tumor. So in terms of cystic changes, in terms of vascularity, so when it comes to cystic changes within the tumors, they are the negative tumors. That means there is no viable tissue in that.
Right.
You do a biopsy, you may get inadequate material and sample get destroyed instantly. But when you do at a vascular area, when a firm area, when you get a very good sample. And that sample is very important for a pathologist to see whether it is viable or not. Once it is viable only, they can describe the lesion much better.
Okay.
And also we have to do a biopsy at a different layers of the tissue.
Right.
So deeper tissue, middle tissue and the anterior tissue. So we have to take at least 3 to 4 samples in different angles. So then we'll be able to pick up the optimal image
So
capture.
the expertise here becomes very important, specifically in smaller tumors and the ones that have cystic changes.
Yes.
So you've been practicing for 20 years, and I'm sure when you started off, breast cancers would usually come in very advanced stages. And do you think the education, the kind of media portrayal of screening has also helped in detecting cancers at a very early stage? And what have you seen the breast cancer screening evolution in your clinical practice over the last 2 decades? And have you started seeing a lot of early cases in the present scenario compared to what you're seeing probably a decade ago?
Definitely. The education level of the general population has increased. So they started going more for a health check. So in the health check, the mammography is also included. So we are detecting more cancers before actually patients get the symptoms. So that is because of health checks. So that is what the difference between the Indian screening and the Western. Western, the national driven. So everybody have to go for mammogram. Here, it is an individual. We have to shell out their money and get the mammogram. So very few people voluntarily get it done. And those are the cases which are detected in a very early stage, less than 1 centimeter, and they have a very long survival.
Is it possible that a same mammogram rated by 2 different radiologists to give 2 different risk categorization?
Yeah, that is definitely makes a difference, because here, as I mentioned about the Doppler, which gives the internal vascularity of the lesion. So that can be normal in a young age. The same thing is abnormal in an postmenopausal age. So that expert makes a difference.
Yeah, so it's quite possible, because we have seen cases where a mammogram has been reported normal outside, but when they come to us, we actually would have seen some abnormal areas that is there in that screening mammogram done earlier itself.
So one other important question is, we also see a lot of men also having cancers as well. Do you also see men also getting screened for male breast cancers using ultrasound?
Yes, we do get cases like this, but most of them they come for to rule out gynecomastia. So that is related with the hormonal tablets, some antifungal agents, and alcohol. So there are so many other physiological factors which will enhance the normal breast in a male. But when it comes to malignancy in a male breast, they are very aggressive. So generally, malignancy in a men, it comes as a very hard lump. It comes a little in the later part of life, like 6th or 7th decade of life.
All right, so there is a lot of artificial intelligence coming up in the medical space, specifically when it comes to radiology, to automate reading, be it X-rays or mammograms specifically. So what is your viewpoint of that? Do you think those are reliable parameters? Having said that, between two radiologists itself, there can be difference. Is AI going to make this difference become lesser, or is the difference going to be amplified?
So AI is going to add a value when you are doing a mass screen. Let us say you are going to do a mammogram of 1 lakh or 2 lakh people in a state where it is literally becomes impossible to read all the mammograms. So here AI will add a value where it can triage high risk, moderate risk, and low risk based on the density, high density, moderate, and low density. So based on that, it can categorize and give it to us. When it is a fatty breast, it hardly takes 5 minutes for us to read. But same thing, you give me a dense breast, it takes at least 15-20 minutes to read. And I need to have a previous year's comparison. So AI is going to add a value when you are going to compare with the previous mammography records done in a different institute. So when you have to pick it from the cloud and read the images, there the comparison and the type of density AI is going to add value.
So it is more about augmenting a radiologist's brain. So it's going to augment your probably workforce, or probably reducing the time of reporting as well when you're dealing with large amount of data. I think that is
definitely when you're looking at a large amount of data. Suppose a patient comes with 10 years of mammogram. So we have to collect all 10 years of data. So instead of that, any asymmetrical density in the last, it can pick it up.
Right.
So there we will have a
Save the
relook
time.
at. Yeah, we will save our time and we'll describe more in that asymmetrical density, developing asymmetry part of it.
But would you be comfortable releasing the report without reviewing what AA has told?
Definitely, because AA can give me a suspicion of the lesion. But again, even I have to see, confirm the lesion, then I have to do an ultrasound scan. If ultrasound scan is not possible, then I have to do a spot compression. Then we have to confirm the disease. So just based on the AI, we cannot diagnose the disease.
So you can use it as a good assistant.
Yes.
Have you ever got, a cancer on a mammogram and ultrasound where the patient has become really emotional and probably you have defined the weight of hope, the kind of emotional outburst a patient is at, where you've detected the cancer very early? Do you have any clinical scenarios where you felt overwhelmed with an emotional outburst of a patient?
Yeah, I have one patient like that. She just came for a routine health check. In fact, she came with her sister, and after her sister got mammogram, she wanted to just check. And when we checked, I detected a lesion of 3 millimeters. It was the smallest tumor I had detected, and even she could not believe. And the surgeon also was like, "How can you detect such a small lesion?" So we did a biopsy, and it was a stage 0. Even the lymph nodes were negative, and she is almost like since 12 years she is there without any disease. So that is one thing,
So
which is like screening mammogram can detecting asymptomatic such as small lesions. It is
and
amazing.
in fact, not just screening, even with your biopsy, to correctly biopsy a 3 millimeter lesion, it needs
It's finesse
expertise.
and expertise.
More often we see that they take it from the nearby tissue, it comes out to be negative, they come back after a few months, you see it growing, and then they are able to do a good biopsy.
So we have to do a precision biopsy. So where when comes to a smaller lesion, we do something called vacuum assisted breast biopsy.
Okay.
So where you go close to the lesion, even if you miss it, it can on the suction. That suction will pull the lesion towards a needle. There you can rotate the needle without removing it.
Right.
So there you get a good sample.
Correct. So this is where exactly the expertise of a breast radiologist comes in, and with India progressing more towards detecting early breast cancers than late, I think these expertise is what is going to make the difference.
Yes.
So when you do the screening process, you detect breast cancer lesions in many of the patients. Do you break the bad news or do you let the clinician break the bad news? How do you manage, breaking the bad news? Because cancer itself is, emotionally downtrodden. It pulls the patient down. The fear of, being told you have cancer itself is way too much for anybody to take. Do you break the news or do you send it back to the clinician to break the bad news?
So it is double-edged sword. If you break the news as a bad, they crash in the same time. And many of the time, they will not turn up also. So they think it's the end. So instead of telling it like this, I will tell like there is some small lump is there. Let us see what we can, how to prove the disease, whether it's infection or a tumor. We'll do a small little test. The same thing I'm going to put it in the report.
Perfect.
So we'll not disclose it on the straight, and they'll be okay with it.
I think how
by the
it
time.
works is it's a teamwork as well. So
Yes.
I send a patient to you and then you evaluate, you see some suspicion, you give a certain scoring, and then we discuss, about the biopsy, and then probably as a team we do discuss, the possibilities of the person having cancer, and then we as a team will disclose to the patient about the cancer diagnosis.
So we spoke a lot about outside diagnosis being missed and you picking it up here with a nuanced biopsy. Talking of the reverse scenario, have you had patients who has been called or named as cancer coming to you and then you finding out via imaging that it wasn't actually a malignancy, it was something that was not cancer?
Yeah, that scenario is also there because there are certain diseases where it is a pre-malignant conditions. Something in a FNAC when they do, you don't get the sufficient samples, which is difficult for a pathologist to report. In such cases, we have to do a biopsy. So generally for breast diseases, breast lesions, FNAC will not give a good this thing. We had to do a biopsy. So there are cases where with the FNAC they would have given us atypia. It is a mild pre-malignant condition or suspicious. So they will suggest for a biopsy. When I did a biopsy, it comes negative.
Right. Okay. So
So it is an error of the sampling. So it is always better to use a biopsy than FNAC.
right.
So, I mean, we are celebrating the Breast Cancer Awareness Month. So, do you think it is advisable only to, like, talk about breast cancer just in this month rather than making it as a government protocol or making it more aware? Because breast cancer itself is growing leaps and bounds because of our lifestyle. What is your take on this aspect? And probably more amount of media coverage, more amount of governmental initiatives should have been incorporated into our, regular education to our population.
So here there is two scenarios. One is the education about the breast disease. Not all the lumps are malignant.
Right.
So they should not get panic. Same time, they should be able to conclude whether it's a benign or malignant. So you educate them to just have a self-breast examination, how to do the self-breast examination, when to do. And second thing is, if they felt a lump, then what next to do, where they had to go. So whether it is a government-driven screening system or it is done by themselves. So whenever they feel a lump, it is definitely required to show to a doctor. If not able to go, they had to do a mammogram or ultrasound scan. Then we'll be able to definitely conclude whether it's a benign or malignant.
Right. Right.
So, to conclude, which is the scan in your 20 years of practice which is stuck onto your mind, or when you remember, okay, fine, this is the impact I've created, or something which is very unusual where you've saved a life?
Yeah, there is one ultrasound is there that's called ultrasound elastography. So that is a technique very rarely been used by other radiologists because that depends upon the machine and it is developed skill. So elastography is a technique where you know whether the tumor is harder or soft. So when the lump is harder, it is more towards a malignancy. When it is softer, it is more towards a benign. So even without doing a biopsy, I can classify or I can raise a suspicion or drop my suspicion on the tumor, on the lesion. So that gives me a very good, indication to do a biopsy or not do a biopsy. So that is the game changer for me to, get the more expert opinion on the breast imaging.
Better than an ultrasound.
Yes, it is an ultrasound, but it gives
Additional feature.
more additional features in describing the lesion and how far is the extent of the tumor, which will be useful for a surgeon to have a breast conservative this thing. And we can also pick up small lesions, which are called satellite lesions, which we are going to miss it on the regular mammogram and even an MRI, but we can pick it up in the elastography. So whenever it is a woman, she goes to various physiological changes in her body. It's whether it's a menarche, whether it is a pregnancy, whether it's a lactation or a menopause. So there are so many phases in her personal life. So here, when it comes to young age, they feel uncomfortable to have a breast. But when it comes to a reproductive or pregnancy, they know what is the value of the breastfeed. But after the pregnancy and after the lactation, after feeding the baby, they ignore the structure. That's where the majority of women, they ignore that, okay, it may be just a milk clot. No, it's okay, it is okay. So majority of the women, they ignore the lump thinking that it is a benign. Because it is a painless lump, they ignore it. So let me tell you, all painless lumps has to be examined. Unless otherwise proved, you have to get it examined. Whether it's benign or malignant is a different thing. But you have to examine all painless lumps.
Yeah, that was a very important bit of information.
I think the most important thing is when awareness becomes education, it saves a lot of lives, and that is what you have said. And it's been amazing to interact with you and to be educated about breast cancer screening and the importance of mammogram, ultrasound, and other imaging modalities which you use in clinical practice. It's a pleasure having you, Dr. Sudhakar. Thanks to be on the show.
Thank you.
Yeah, thank you so much.
So one scan today can rewrite tomorrow, and that is what Dr. Sudhakar has educated us today. And we celebrate October as Breast Awareness Month, and we would urge our viewers to get breast cancer screening done at the nearest hospital, and you can contact Dr. Sudhakar below the number given. Thank you.
Thank you so much. So it's not just enough that you go for the screening. It is also important that you have the awareness to know that you're in the right hands, which is why an expert oncologist opinion always matters, like Dr. Sudhakar's. Thank you so much.
Thank you.